scoring systems,
Yes, Natesh.
etc. So we'll be starting with Dr. Prem. So Dr. Prem, we can just take it forward. Thank you.
Yes, please.
Dr. Prem, are you there? Can you start the presentation?
My first topic for today is surveillance cultures. So, surveillance cultures basically it's defined as microbiological tests performed in the absence of clinical infection, and it's basically designed to detect colonization by pathogens. And the main goal is to identify silent carriers, prevent transmission, and infection control strategies. So, what are the rationale for surveillance cultures in the ICU? So, usually we all know that colonization precedes infection. So, colonization can be a prerequisite for invasive infection. Example, nasal carriage of MRSA is strongly associated with subsequent MRSA bacteremia or BAP. So, surveillance thus enables early recognition of patients at risk. And also, when it comes to high risk environment like ICUs, where we have vulnerable patients, invasive devices, and high antibiotic pressure. So, these all create a perfect storm for MDR organism mechanization and spread. And also, the risk of cross transmission. So, without surveillance, outbreaks also can happen, which may go undetected until overt infections occur. So this also helps in infection control measures. Why? Because identifying colonized patients allows timely initiation of contact precautions, isolations, or intranasal mupirocin and chlorhexidine baths for MRSA. MRSA may reduce infection risk. And when coming to empirical therapy guidance, survivable information, for example, if a patient is known to be colonized with carbapenem-resistant Klebsiella pneumoniae, empirical therapy may include ceftazidime, avibactam, or polymyxin rather than carbapenems. So thereby it helps in tailoring empirical antibiotic therapy also. And also it helps in aggregating surveillance data. It helps in tracking resistance patterns, assess the impact of infection control programs, and antibiotic stewardship policies. So, what are the common indications of surveillance cultures in ICU? A routine admission screening, a few centers recommend. Rectal swabs, example rectal swabs for VRE or carbapenem-resistant enterobacteriaceae may be mandated during outbreaks or in endemic regions. In higher risk patient groups like burns patients or transplant or immunocompromised patients, or those who are having prolonged ICU stay, you can use surveillance cultures. Outbreak investigations, and environmental surveillance are essential to identify risks of surveillance cultures in ICU. Coming on to methodology and sampling sites. So patient sites like nasal swab can be sampled for MRSA, rectal or perianal swabs so am I audible?
Yes.
Okay. So, coming on to the limitations and challenges of surveillance cultures, it is resource intensive because it usually requires laboratory manpower, consumables, and isolation facilities. And coming on to the predictive value, it has got an uncertain predictive value because all colonized patients doesn't develop infection, and unnecessary isolation may consume resources. So, so it has got contamination or sampling errors can mislead infection control measures, and there are a variation in global practices. That is universal screening versus target screening based on risk and local epidemiology. So there are a variation in global practices and antibiotic stewardship concerns. So knowledge of colonization bias clinicians towards difference between surveillance and uh, diagnostic cultures. So the purpose of surveillance cultures is to detect colonization, while diagnostic cultures are to identify active infection. Timing, usually it's routine or periodic when it comes to outbreak. So coming on to diagnostic cultures, when infection is suspected, you take a diagnostic culture. And action based on surveillance cultures would be isolation or cohorting the patients. While based on diagnostic cultures, you give a targeted treatment. And organisms usually identified by the surveillance cultures are usually your MDR organisms related based on the organisms which are and CDC guidelines recommend surveillance cultures in outbreak control as well. This is a future directions. You can use rapid molecular diagnostics like PCR and genome sequence. Basically a microbiological test to detect colonization by multi-drug resistant organisms and not. So common which are sampled are nasal swabs and rectal swabs and tracheal aspirates. So diagnostic cultures are performed when it's causing clinical illness. It's not aimed at identifying colonization with multi-drug resistant organisms. It helps in antibiotic stewardship. It helps in tailoring empirical therapy, empirical antibiotic therapy to isolate antibiotics. So this is about the first topic. So can I proceed to the second topic?
Arvindam sir, can you present the four topic and have a discussion, or shall I have a discussion per topic? Arvindam sir, can we proceed with the next topic, or can we have a discussion now?
So I think you can go ahead with the
Shall I
next
proceed, sir?
topics.
Yes, Prem, you proceed.
Okay.
Topics will have a discussion.
Okay.
Thanks.
Okay. So this is the second topic for today. It's about focus, training, and accreditation. So this is a question. So a newly joined ICU trainee attempts central venous access using ultrasound guidance under your supervision, but struggles with probe orientation and needle visualization. Later, you notice that there is a mid-center pretend cardiac focus image. So uh, question is regarding a role of focus in vascular access and cardiac evaluation, and also about the competency thresholds for ICU focus in procedural guidance and cardiac assessment. So coming on to focus, focus is point of care ultrasound. It refers to the bedside use of ultrasonography by treating physician. And we are focused at answering focused clinical questions guiding interventions, and to monitor treatment response. In the ICU, where rapid decision making is crucial, focus has emerged as an important extension of the clinical examination, and it allows dynamic, repeatable, and radiation-free assessment of critically ill patients. So, despite widespread utility, ultrasound is highly operator dependent, and misinterpretation can lead to inappropriate clinical decisions. So, therefore, structured training, supervised practice, competency assessment, and formal accreditation are essential to ensure safe and effective use. So, several critical care societies have developed various frameworks for training and accreditation. So, coming on to the clinical utility of focus in critical care, it aids in both diagnosis as well as procedure guidance. So, the main areas relevant to ICU are: first one, most important, is vascular access. So, real-time ultrasound guidance improves first attempt success for central venous and arterial cannulation. It reduces complications such as arterial puncture, hematoma, pneumothorax, and catheter malposition, increasingly considered as a standard of care for central venous catheterization. Coming on to cardiac function assessment. So basically, POCUS can be used as a tool for a critical care cardiography, provides rapid assessment of LV systolic function, RV function, pericardial effusion, and tamponade, and thereby helps in evaluation of shock states. So coming on to the next use, it's basically fluid status and hemodynamic monitoring. As we all know, the IVC collapsibility or distensibility indices is based on utilizing POCUS. Also, you can assess the LV and diastolic pressures, stroke volume variation, and passive leg rise. And pulmonary congestion also can be assessed with the utilization of V lines. Coming on to lung and pleural ultrasound, it helps in detection of pneumothorax, that is absence of lung sliding and a barcode sign with a lung point usually. It helps in differentiating pulmonary edema, pneumonia, and atelectasis. Also quantifies pleural effusion and guides safe thoracocentesis. Coming on to abdominal and procedural applications, it helps in diagnosing or detecting ascites and paracentesis guidance, identification of hydronephrosis, urinary retention, or biliary dilatation, and helps in bedside guidance of percutaneous rectostomy, nerve blocks, and difficult airway. So coming on to principles of training, the training pathway should be structured, stepwise, and competency-based rather than time-based. So the key principles are: one, didactic teaching, that is based by teaching the basics of ultrasound physics, image acquisition, knowledge, and probe orientation, along with indications, limitations, and artifacts. Then next step is the simulation training, where we get initial exposure using mannequins and task trainers, provides risk-free practice in needle guidance and image interpretation. And next step is the supervised clinical scanning, which includes performance of scans on real patients under expert supervision, and also immediate feedback, which is critical to correct errors early. So coming on to the competency assessment, so evaluation of image acquisition skills, interpretation accuracy, and integration into clinical reasoning, and use of structured assessment tools and direct observation. These are the methods by which we can assess the competency of a personnel doing POCUS. Next step is a credentialing and accreditation. So documentation of minimum scan numbers in a logbook, structured examination, which includes theory, practical OSCEs, and image interpretation, and periodic revalidation to ensure maintenance of skills. So these are the steps that are included in credentialing and accreditation. So competency requirements, so you have to get competency in 3 areas. One is image acquisition, image interpretation, and clinical integration. So these are the key areas where you have to get competent. So these are the training standard and minimum requirement recommendations. So this may vary across regions, but the broad guideline is that we have to have at least 20 to 25 supervised procedures for a vascular access. When coming to lung ultrasound, minimum of 20 to 30 supervised scans covering common pathologies. Coming on to cardiac ultrasound, around 30 to 50 supervised scans across diverse pathologies. Coming on to abdominal ultrasound, at least 20 scans, including ascites, hydronephrosis, and bladder scans. And this supervised practice, should ideally be documented in a logbook with formal feedback. And most societies emphasize that numbers are indicative. Competency, not volume alone, determines readiness. So these are the accreditation frameworks that are available. So the Society of Critical Care Medicine and American College of Chest Physicians offer structured focus training pathways, which is based on modules. We have a training pathway by the European Society of Intensive Care Medicine as well, which are of two different levels, basic and advanced levels. Indian Society of Critical Care Medicine also provides fellowship level focus training, and various national boards and accreditation bodies are also available, with which recognizes focus competency as part of fellowship training in critical care medicine. So this is the key summary when come so about focus. So focus aids vascular access, cardiac function, and fluid status. And competency focuses on image acquisition, interpretation, and supervised practice, as I have already mentioned. Training should progress from simulation to supervised scans to credentialing. So minimum scan numbers and feedback I have mentioned. So this is the summary of this topic about focus. Can I move on to the next topic, sir?
Yes, Prem, we can just all 4 topics, then we can have questions.
Okay, okay. So coming on to the next topic, it's about cleaning and disinfection in the ICU. So the questions for discussion are basically the methods of surface disinfections used in ICU and the limitations of fumigation in outbreak control, and also the use of shoe covers, whether to use or not to use. So environmental contamination of surfaces, equipments, and healthcare workers' hands basically are strongly linked to the transmission of MDR organisms, including MRSA, VRE, or ESBL organisms, Acinetobacter, and more recently we have cases of Candida auris as well. So rigorous cleaning and disinfection protocol are therefore very important. Coming on to cleaning, it's the physical removal of organic and inorganic material from surfaces, usually using water and detergents. And it's an essential prerequisite to disinfection, as organic material can inactivate disinfectants. So that's basically cleaning. Next is disinfection. It's the application of chemical or physical agents to eliminate most pathogenic microorganisms and not necessarily spores from inanimate objects. That is disinfection. So that's basically cleaning and disinfection. When coming on to sterilization, it's a complete elimination of all microorganisms, including spores, and usually reserved for surgical instruments and not feasible for environmental surfaces. And there's something called terminal cleaning, where it's the intensive cleaning and disinfection of a patient's environment after discharge or transfer or death to prepare the space for next admission. That is terminal cleaning. So methods of disinfection in the ICU, we have various methods. First important is the routine cleaning and high-touch surfaces. So high-touch surfaces, that are the bed rails, monitors, ventilator knobs, infusion pumps, keyboards, acts as a major reservoir for multi-drug resistant organisms. So detergent-based cleaning followed by disinfection is recommended at least once daily and more frequently in outbreak settings. Coming on to chemical disinfectants, we have alcohol-based wipes. There is 70% isopropyl alcohol or ethanol. So this is basically a rapid-acting, broad-spectrum cover against bacteria, mycobacteria, and viruses. Evaporates quickly, leaving no residue, and it's ideal for small surfaces and equipment like stethoscopes, ultrasound probes, and monitor screens. Limitations are it's basically ineffective against spores. So it's about alcohol-based wipes. We have sodium hypochlorite as a chemical disinfectant also. So it's widely used for floor cleaning, body fluid spill management, and terminal disinfection. It's effective against bacteria, viruses, and fungi. For large blood spills, instead of 0.1%, 1% solution is recommended. Limitations are basically it's corrosive to metals and has got a bleaching effect, and it is inactivated by organic matter. So coming on to next chemical disinfectant, it's a quaternary ammonium compounds. It's used generally for surface cleaning and non-critical equipments. It's got good detergent properties. Limitations are it has got reduced efficacy against spores and certain non-enveloped viruses. Coming on to hydrogen peroxide and parasitic acid formulations. It's highly efficacious, including activity against spores, used in automated room disinfection systems, and it's relatively environment friendly because it degrades to water and oxygen. Coming on to physical disinfection methods. So we have ultraviolet light systems. It emit ultraviolet C radiations, causing DNA damage in microorganisms. It's a useful adjunct to terminal cleaning, especially in outbreak control. And it's effective against spores as well and MDR organisms. Limitations include no residual effect, requires empty room, and line of sight exposure only. So these are this is about ultraviolet light systems. Coming on to vaporized hydrogen peroxide. This is also a physical disinfection method. It creates a fine mist that penetrates surface and equipment. And it is broad spectrum again, effective against bacteria, viruses, and spores. And it's increasingly used in high-risk ICUs for terminal disinfection. ICU disinfection. So when coming on to certain equipments and devices, we have monitors, ventilators, dialysis machines, and infusion pumps, which has to be wiped with alcohol-based disinfectants compatible with electronics. We have ultrasound probes, which should be wiped with alcohol-based solutions for sterile procedures, and probe covers plus high-level disinfection is required for sterile procedures. And coming on to beds, mattresses, and trolleys, it's disinfected with hypochlorite or hydrogen peroxide. So coming on to floors and furniture, we use routine wet mopping with hypochlorite usually, but dry sweeping is also it's usually discouraged as it disperses dust and organisms into air. Soft furnishing has to be disinfected. It usually replaced regularly, and disinfection and laundering are necessary. So soft furnishing include curtains, privacy screens, and linens that can act as reservoirs for MDR organisms. Shoe covers has got less evidence. So evidence or efficacy in preventing hospital-acquired infection is weak. It may increase floor contamination outside ICUs if improperly removed. And it's recommended only in high-risk units such as transplant ICUs or during outbreaks of highly transmissible pathogens. Otherwise, it's not routinely recommended. Coming on to terminal cleaning protocols. So, terminal cleaning is a cornerstone of ICU infection protocol. So it should include removal and disposal of waste and consumables, cleaning and disinfection of bed frames, mattresses, and bedside furniture, disinfection of all high-touch equipments, floor and wall cleaning with hypochlorite or quaternary ammonium compounds, replacement of linens and curtains, and optional adjuncts such as UV radiations or vaporized hydrogen peroxide for enhanced terminal disinfection, and documentation using checklists with infection control nurse verification. These are the protocols which can be used for terminal cleaning. What are the challenges in the implementation of the same? So we should be having some compliance to the measures. So human factors and shortages can reduce adherence. Turnaround time. So rapid patient turnover limits thorough terminal cleaning. Organism resistance, like environmental persistence of Acinetobacter and Candida auris. These organisms are highly resistant to conventional agents. And equipment damage. Some disinfection can corrode sensitive electronic devices. And for monitoring effectiveness, it requires periodic environmental cultures or bioluminescence testing. So these are the challenges that we face for implementing terminal cleaning. So this coming on to the summary. So we have discussed the disinfection methods, including sprays and wipes, alcohol wipes, hypochlorite, and UV light. we have understood that fumigation has got poor penetration and no residual effect, so largely not recommended. Shoe covers have limited evidence and recommended only in high risk zones. And terminal cleaning protocols, as I've already mentioned, they are very much essential. So this is about the third topic. So coming on to the next topic. So this is the fourth and last topic, statistical curves and plots. So these are the questions: interpreting an ROC curve and explaining the significance of area under the curve in ICU diagnostics. And how is a Kaplan-Meier curve used to assess survival in ICU trials? And describing a funnel plot. So coming on to the ROC curve, it plots sensitivity versus 1 minus specificity for a diagnostic test. So if the area under the curve is 0.5, there is no discrimination. If it is 0.9, it's outstanding. So this is the typical ROC curve. So you can have a look once I share the slides. So as you can see that 0.5, where if the area under the curve is 0.5, we don't have any discrimination. While if it is, as the curve is towards the left upper quadrant, it has got increase in sensitivity. So what are the uses of ROC curve? It's basically it can be used as a it shows how well a classification model performs across different decision thresholds. It helps in understanding the inherent validity of a diagnostic test or machine learning classifier, and also helps by analyzing the trade-off between sensitivity and specificity at various threshold. We can choose the best cutoff point for a given application, and helps in comparing two or more models. It provides a way to compare the performance of different classification models. So this is a chart that compares ROC curve and the area under the curve. What does it exactly mean? I'm not going to read it in detail. Every thing we can have a look later. So what are the clinical applications of this is the last slide, I suppose. So next, coming on to Kaplan-Meier survival curve, we have got an x-axis and a y-axis. X-axis is basically time, and y-axis is probability of survival. And stepwise curve, which shows survival decline over time. So this is basically used to estimate the probability of survival over time, especially in clinical trials and outcome studies, and accounts for censored data. So these patients who are lost to follow-up or haven't yet experienced the event. That is, death patients or discharged patients. So this is basically, as I've already mentioned, x-axis is the time and y-axis is the probability of survival. And it looks something like this here, the Kaplan-Meier curve. So each drop represents an event, that is, example, death, and flat segments indicates no events during that interval. We have vertical ticks or symbols on the curve to show censored patients, and there can be optional shaded areas around the curve showing statistical uncertainty, and there can be an area, a number which is shown below the graph indicating how many patients are still being followed at each time point. So this is the final summary of the last question. So ROC curve we have discussed. Basically, it illustrates the diagnostic ability of a binary classifier. It plots sensitivity, that's the true positives, versus 1 minus specificity, that's basically the false positives. So area under the curve quantifies overall test performance. Area under the curve of 1 indicates, or 0.9 indicates perfect test, while 0.5 suggests no discriminative power. Coming on to Kaplan-Meier plot, it's used for survival analysis, and it estimates the probability of survival over time and compares survival between groups using log rank test. Funnel plot I've not discussed. So this is about the last topic.
Thank you, Dr. Prem, for the presentation. So actually, you have heard the four different topics because we don't want to have a monotonous presentation. We deliver topics accordingly. So in that, the few key points, what I want to suggest is when you read the question, you try to see the verb. For example, define, describe, and critically appraise. So these are the words you should concentrate. Accordingly, you should write the answer. If something is asked, what are the different types of disinfection, you have to mention it. Instead of write, describe the different type of disinfection. I mean, each one you have to write a couple of sentences regarding. So that's the most important thing because the answer keys will be kept accordingly. And here, if you see the each question is followed by one summary slide where specifically I mentioned few things called something called must know, few called good to know, and something nice to know. Like must know points, you are supposed to know. If you don't write the must know points, and you may not get correct marks. And to give example in a septic shock resuscitation, and if you mentioned lactates, and if you mentioned the fluid, etc., but you forget to mention taking cultures and giving antibiotics, then actually you will not get marks because they are must know points. You should never forget. It's a great impact. Similarly, the must know points are the points where actually you are supposed to write it on the topic key points. Good to know things is decently a slightly better knowledge about all these points, mentioning few studies, quote few studies, and compare the literatures, add your points, etc. Nice to know point is up to maybe if you want to give a additional perks, additional 1 mark, extra marks, and you can mention little bit more on the robust evidences, your own opinions you can add, and something slightly related topic that is not completely focused may add extra points to that. So like that, nice to know points are there. So you can divide the topic when you write, what are the important things, write, don't forget it. And other things you can just see depending upon the questions. If you see the surveillance, we have a define. So the surveillance was actually defined it. Here the key points, what you mention is the surveillance for colonization to identify. That word should be there. And if it is exactly the diagnostic cultures means it's like after suspected infection you are sending it. So these two are important points. Why you are doing it? What are the indication that actually Dr. Primus mentioned? In a similarly, see the POCUS, and in that the specific question is discuss the role of POCUS. That means you have to describe why the POCUS is important in terms of vascular access, how it is useful for us, starting from anatomy to guidance to looking for complications, checking the placement, etc., everywhere. So all these things can be should be described. Similarly, if you want to see the critically evaluate the accreditation process, we have to evaluate different societies how they mention. So it depends upon how many numbers. Some depends upon your how you actually acquire and interpret, etc. That has to be described. And you can compare between societies and you can give it your own opinion. And these are the points I should go through. And similarly, in the last two things, cleaning and disinfection is quite it's a little dry topic, but quite straightforward, very commonly asked. Here, describe methods, a lot of methods. You can categorize the methods. That becomes more easy for the examiners to easily correct it. Once you categorize, we know which category it falls, and few important things, which instruments. So, Gulter is commonly used for bronchoscope. That you mentioned it. That's we know. Okay, this instrument he knows. Quaternary ammonium compounds when it is used. So, like that, if you keep one examples, that'll be very useful for examiners to quickly screen through the paper and quickly correct it. That has to be highlighted. And the final one is on statistics, like ROC curve versus the area under the curve. Area under the curve is nothing but a number. ROC curve is a completely a concept. It tries to discriminate, and for example, it can differentiate between one to other. The discrimination is one of the most important diagnostic ability. AOC people may get confused. It is nothing but the number what is given for the ROC. It is between actually 0 to 1. Commonly 0.5 is a neutral cutoff. 0.5 to 1 is little towards better one. Less than 0.5 is a completely poor one. Anything more than 0.8, we take it as clinically significant. That ways. So accordingly, you can just see. And many points Dr. Prem has already covered. If you have any questions, I can explain you, or else we can move to the next speaker. Any questions from anyone? Prem, you can stop sharing your slides so that
Okay, okay, sir.
Dr. Rahul can.
Okay, sir. Thank you.
Meanwhile, I can address a few questions from you. Anyone has any questions? If you have any queries, you keep putting in the QA chat box. I'll answering you in between also. And Dr. Rahul is a consultant internship from Caritas Hospital, Kottayam. He'll be dealing with another 4 important topics. And over to you, Dr. Rahul.
Thank you, sir. Good evening, all. Our first topic for today will be ICU quality indicators. So the probable questions that can be asked in this domain is mention the quality indicators. We need to know the different types. We need to know the basics about all these things and how what are the challenges in improving outcomes by tracking these metrics and how do you integrate this into ICU environment. And also they might ask you, they can give you certain values and they try to interpret these values. We will discuss that. So coming to the quality indicators, a screening tool, it is used to identify suboptimal clinical care. It is divided into either structural indicators, where it is mainly based on the infrastructure, technological, organizational, and human resources, or the process indicators, which is the existence of protocol and your compliance to those protocols, and the outcome indicators, which is um, the measure of the outcome. So one sec, I am not able to see the screen. One second. So, okay. Okay. So outcome indicators, basically it includes your mortality, morbidity, and the outcomes of the ICU. So what are the quality indicators in ICU? This is, I have taken from the ISCCM guidelines. They have divided into certain parameters, which includes your mortality parameters, that is your standardized mortality ratio. You have certain morbidity parameters, operational parameters, error and safety parameters, infection control parameters, and overall employee and patient satisfaction also. So coming to the first mortality parameter, that is a standardized mortality ratio, which is also called the risk-adjusted mortality rate. Here, SMR allows comparison of actual performance of ICU with the predicted performance. You need to know the formula for calculation of SMR, which is the observed rate of mortality divided by the risk-adjusted expected rate into 100. The risk-adjusted rate is taken from predictive models such as Apache, SAPS, or MPM. More commonly, what we use is Apache for prediction of mortality. And how do you interpret this? If the SMR is equal to 100, then it means that the hospital's mortality rate is equal to the expected mortality. If it is more than 100, it is higher than expected rate. And if it is less than 100, it is lesser than expected. So the benchmark for SMR is given as if the 95% confidence interval is calculated and if the value lies includes 1, the performance is considered average. And if it is less than 1 or greater than 1, it shows good and poor performances respectively. When you want to compare different ICUs with SMR, you need to plot it to a graph. So the width of the graph is actually representing the precision of the SMR estimate. So if you see the initial part of the graph where the number of admissions are very low, you tend to overestimate your SMR. So the width is very high. As it goes narrower and narrower, it becomes more precise. So the dotted lines indicate the 95% a 95% confidence interval. So anything that lies beyond that is considered as higher than mortality. So what are the limitations of comparing ICUs with SMR? One is that all pre-ICU care and inter-ICU transfers, all of this are not accounted for. And it ignores the differences between a different case mix. It can different patient types or severity. So none of this is taken into consideration when you're calculating SMR. And mortality is again not a surrogate of quality of care. It is it depends on a lot of different factors and also your admission and discharge practices. Coming to the morbidity indicators, I will just run through just the headings because of the constraint of time. Your morbidity indicators include iatrogenic pneumothorax. You need to know the description formula and try to know the benchmark, which is around 0.83 per 1,000 cases. Next morbidity indicators is the incidence of acute renal failure in non-coronary ICU. You need to define the definition for ARF and formula for calculation and the benchmark. So next is the decubitus ulcer. Uh, Coming to the operational process or process parameters, the first one is the length of stay in ICU. So length of stay is usually used to assess the quality of care and resource utilization. It is again influenced by number of factors. It depends on your admission and discharge policies, your mortality rates. So this parameter also should be interpreted carefully. So different benchmarks are there in different ICUs. These data are from US studies, which is given in our ICUs ISCCM manual. And next is compliance to protocol. You are expected to have a compliance to selected guidelines, protocol, and treatment bundles. Around 90% compliance is expected. ICU readmission rate includes your ICU readmission within 24 hours, and some data says that 48 hours. A zero admission rate reflects a more defensive approach, and which increases your length of stay and other complications. A higher readmission rate can indicate premature decision to shift out. So either way, both are probably not good, and you need to have a benchmark of around 5 to 6% is what is recorded. So coming to the next parameter, it is the error and safety parameters, which includes your patient's fall rate, your number of medication errors that is happening, number of error rates that is happening, and the needle stick injury rate, and also the reintubation rate. Next is infection control parameters, mainly includes your ventilator associated pneumonia, central line associated bloodstream infection, and your catheter associated UTI. So all these three can be asked as a separate question. You need to know the different headings. You need to know the different definitions, which is the NHSN and CDC definition. When do you say it as a ventilator associated condition, infection related ventilator associated condition? So I will be sharing these slides, so I will not go into detail. And you need to also know when can you say it as a probable VAP. So when you come, it is taken as a quality indicator. The formula for this is important. Number of patients with VAP divided by the number of device days is taken and into 1,000. So any infection control parameters, the denominator is almost the same, which is always the number of device days. And the benchmark of our 1,000 device days by the NHSN is different for different ICU. For medical ICU, it is taken as around 2.5 per 1,000 device days. Central line associated, again, you need to know the NHSN CDC definition, and also how do you differentiate it from CRBSI. CRBSI is more of a clinical diagnosis, and it has stricter diagnostic criteria, and your CLABSI is more of a surveillance parameter, and the definition is more relaxed for CLABSI. So again, your formula here, number of central line associated BSI recorded by the number of device days into 1,000. It is easier to remember. And the benchmark is again different for different ICUs. Benchmark for medical ICUs again around 2.5 to 2.4. Next is your catheter related UTI. Know the definition. Formula is the same number of UTI by the number of catheter days. The benchmark for medical ICU is around 4.1. And we have two other quality indicators, which includes your overall employee satisfaction and your patient satisfaction. These are mainly derived from feedback forms with a scoring of around 1 to 10, and the 10 is a best possible service. There are different other quality indicators also, like availability of an intensive care specialist, throughout the day, or patient to nurse ratio, hand hygiene compliance, unplanned extubations, end of life pathway in place. So these can also be mentioned. So coming to that initial question, where you're supposed to choose a better performing ICU from the data. SMR of one ICU is given as 0.9, and the average length of stay is 7.2 days. And another ICU has an SMR of 1.1 and a length of stay of 4.5. And you need to interpret these metrics. So how do we do that? One is when you are asked about SMR, try to describe what it is and tell the formula and interpretation. In this scenario, for ICU1, the SMR is 0.9, which means that it is less than 1. So it is better than expected survival. It is the second ICU is 1.1. It is worse than expected survival. So ICU1 appears to have a better mortality outcome in this scenario. But the limitations of SMR, as we already discussed, depends on the accuracy of the severity scoring system. There are different case mix variations. There are certain units which admit more complex and rare cases, they may tend to perform worse. Uh, it does not reflect on non-mortality outcomes like whether the patient is functionally recovering or quality of life is not included in the SMR. And it is also influenced by your end of life decision practices. So early withdrawal of care may reduce the length of stay, but increases the mortality. When you come into a length of stay, describe it and tell the formula. So here in ICU 1, you have 7.2 days, which is one ICU is having longer length of stay. So short ICU stay does not reflect, may reflect efficiency, but also could mean that there is a premature discharge, or if the patient has a higher mortality rate is there in that ICU. So longer ICU stay may reflect more thorough care, but can also indicate inefficiency or blood blocking. So when you are doing an ICU, inter-ICU comparison, these things are strongly influenced by case mix and admission discharge policies. There can be certain outliers, that is certain patients which has a very prolonged stay. It can skew the averages. And shorter ICU stay is always not better. So it can be because of an early death, or it can be because of unsafe transfer also. So therefore, when interpretation and comparison of two different ICUs should be done with caution, and as it can be affected by several parameters. These trends should be analyzed over time. Observing how the ICU metrics change over time is more important, and instead of checking it in an isolated interval. So to summarize, SMR, we have to know, like the must know points here is SMR less than 1 has better than expected survival. You need to know the length of stay is interpreted by case mix. We already mentioned all this. So WAP, you need to know the standardization, definition, surveillance, training. Good to know the benchmarking of different things to identify gaps and improve care. Read about the NHSN definition and INCC reports. And it is nice to know the automated surveillance tools. Thank you, sir.
Any queries here actually? Because this is slightly a different topic. SMR is quite an important one because it's commonly still used across the globe. Even though it has so many problems, and because that is the only easiest tool available to compare. So because if you tell SMR less than 1 and greater than 1, if you don't tell what ICU, for example, one is a medical ICU, as a surgical ICU, as a cardiac thoracic ICU, there actually the case mix is completely different. So you may not compare one from the other. This is one of the most important drawback. You don't consider. So what is a pre-ICU care given? Because if it's a quite a pre-ICU care given is not very good, and then again that also affect your mortality. You don't give importance to that. That is a major important and a drawback of using SMR. So all these points you have to bring in when you try to write a answer, describe, or maybe critically appraise or compare and contrast. When you're telling that one ICU is better than another, we should include all these factors, considering these factors like that. So this is quite important context here. And always you compare with something called a benchmark. So you may not know, benchmark can be local, can be national, can be international, or from any societies. Like commonly infection control benchmark is well known. We have a lot of benchmarks with us. And when you use across the globe, if you compare with the international standard with your own standard, then we know that you know better the topics. So unless otherwise you mention the important points like the SMRs, what is the advantages, what are the disadvantages, and it's very difficult to understand how much you know about it. That is the beauty of the essay questions. Each answers can be different, and the way you put it is the one that is important. So this is quite important topic.
Explain allocation, concealment, how it enhances the validity. So RCTs are gold standard for able to evaluate any intervention efficacy and effectiveness. People are randomly divided into two groups. So a well-defined RCTs with a rigorous methodology has a high internal validity and acceptable external validity. So based on the type of trial design, it can be divided into either parallel RCTs, crossover RCTs, factorial RCTs. Parallel RCTs are commonly you're just dividing into therapy A or therapy B, and you're analyzing the outcome. In crossover RCT, initially the group receives particular treatment. Then after a washout period, the group receives the other treatment, the other group's treatment. So this is crossed over. And the advantage is that both the same group of people receives the same treatment. This is mainly done for chronic conditions. And in factorial design, it's used to study more than one intervention at the same time. You have different combinations that is tried. Some groups get only one treatment. Some groups get neither of the treatment, and one group may get both the treatments. So it is efficient. I mean, efficient approach for studying combination effects of the treatments and outcome. So based on the hypothesis, type of hypothesis, RCT is divided into superiority trials or equivalence trial or non-inferiority trials. Superiority, you're trying to show that one drug is superior than the other. So this should have adequate power to demonstrate that superiority. Examples are Prosiva trial, which showed a definite advantage of proning, and Corticus trial. Although it was started as a superiority trial, the result was kind of neutral. Equivalence trial, you're trying to show that both the treatment or both the interventions are same. In non-inferiority trial, you're trying to say that the new treatment cannot be said to be significantly weaker than the current treatment. So that includes your Merino trial, which compared Pepso with meropenem, and Durapap trial. So in equivalence trial, complete equivalence means that there is no clinical difference. So if you want, there is a margin of equivalence that is established, and if the parameter lies between the margin of equivalence, it shows equivalence. So in case of a non-inferiority trial also, you have a margin of non-inferiority. And if it lies between this margin, we can say it as this particular treatment is non-inferior. So based on the outcome of interest, the RCTs can be divided into explanatory RCTs or pragmatic RCTs. Explanatory has it tests basically the efficacy of the research setting, and it has highly selected participants under highly controlled conditions. This has higher internal validity, but it is more time consuming and expensive. These are mainly used for experimental and unlicensed interventions. In pragmatic RCT, mainly for testing the effectiveness of a particular intervention. This has high external validity. It is more affordable, and usually the usual clinical practice interventions are tested. So randomization basically ensures that entering into study has equal chance getting allocated into uh, different a fixed randomization we take where each arm, the participants goes to each arm like like by tossing a coin or just rolling a dice. So the problem with simple randomization is that if you have the sample number is very low, you tend to distribute these participants unequally. So if the sample size is 10, you might have two patients in one and 8 in the other instead of a 5:5 this thing. To avoid this complication, you have something called block randomization, where it is divided into different blocks of equal number of participants to ensure that equal number of participants. In stratified randomization, this is mainly done to maintain or stratify people according to the underlying factors, or this is mainly for uh, it controls it equalizes your baseline characteristics. So both the groups have equal number of people, and the baseline characteristics are also matched. in cluster randomization, instead of randomizing an individual, they usually randomize in clusters, that is in groups. Randomization, this is more done for like public health research studies. In adaptive randomization, there is no pre-specified endpoints like sample size. You have a pre-specified superiority or non-inferiority level. So till that this thing is reached, till that adequate number is reached, you can keep randomizing patients into different arms. The next concept that we have to discuss is blinding. So a trial can be open labeled or blinded. It can be named as open labeled or blinded. Blinding can happen at different levels. It helps in eliminating the intentional and unintentional biases and ensure credibility of your study conclusions. So different types of blinding are there. One, it can be unblinded, where everybody knows what treatment they are receiving and they're giving. And single blind is when one of the group is more commonly it is a participants. So one group is blinded and the other group knows what treatment they are getting. The double blind, where the participant or the investigator doesn't know what treatment is getting allotted, and triple blind, even the data analyzer also does not know what are the uh, treatments allocated. So advantages of blinding, that it avoids observation bias. It prevents investigators from influencing how the results are measured or interpreted. In performance bias, if the patient knows that they're in the treatment group, their behavior or response may change. So it avoids this performance bias. It avoids detection bias. If the assessor know the treatment allocation, they may overestimate or underestimate the outcomes. So blinding can increase your internal validity of the trial. And also in certain cases, it can reduce the attrition bias. Attrition is basically the dropout of patients from the study because of some reason or the other. If the patients don't know their group, they're less likely to drop out this a probability. So what is allocation concealment? Allocation concealment is a technique ensuring generating random allocation sequence occurs without the knowledge of the patient who will, uh, without knowledge of which patient will receive the treatment. Concealment actually secures your randomization, and the investigator does not know which patient is in which group. So this can be done in different methods. The central randomization, where it is done by a third party over the phone, or you can have a sequentially numbered opaque sealed envelopes where it is opened only after the patients are allotted. So difference between allocation concealment and blinding may be asked as a question. So you have to know the purpose of allocation concealment. It conceals the randomization. In blinding, you're blinding the participant or the investigator or both. So the people who are involved in allocation concealment is recruiters, and it is done before or during allocation. And blinding comes only after the patient is entering into the trial. So the allocation concealment reduces your selection bias. Blinding reduces your observation bias. Allocation it's always possible, but blinding may not be possible in certain cases like a surgical intervention or something like that. What are the limitations of RCTs? They are not appropriate, ethical, or feasible for all surgical interventions. They may be resource intensive, time consuming, and expensive. May not be feasible for rare and critical situations. There is a lot of potential for various biases, including your publication bias, selection bias, and whatever we have mentioned so far. The external validity is limited because you have a very strict inclusion and exclusion criteria. You may not be able to generalize it into the rest of the population. Coming to ethics in RCT, just a few words on this. You almost always you have to have an informed consent. It's very important that you know how it is taken. Informed consent has been asked as a different question, and all the trials being done has to be registered in the clinical trial registry in India. And this has also been asked as a question previously. So specific to ICU, we have uh, the principles of research, which is including autonomy, beneficence, null maleficence, and justice. It is probably not always possible to um, respect all these principles. Lack of guidelines for ethical conduct of research in critically ill patients. There can be certain conflicts of interest between the physician and the researcher, and they are vulnerable population. So any intervention that is going to increase the mortality they are not going to have they are not going to able to tolerate it. So there is always a lack of consent from, I mean, difficult to obtain a consent because of lack of decisional capacity, or they are too ill to understand. And it is an added financial burden, and also it can be a supplementary stress factor for the clinician also. So to summarize, you need to know what are the types of randomization, what are the methods of randomization, um, allocation, concealment, and blinding. It is good to know the ethical challenges, specifically to ICU, how to take consent in unstable patient or patients who are not able to make a decision. And there are ICH, GCP, and Declaration of Helsinki that can go through it regarding the ethics of taking consent. And it is nice to know adaptive trial designs and Bayesian approaches.
Thanks.
Yes, sir.
So, in this case, the randomization is one of the most important topic because it has a lot of very strong subtopics are there. Each one is a question, like define randomization types and compare and contrast, blinding, allocation, concealment, trial designs. So many are there. In that, actually, if you see the key points, randomization, simple is a equal chance. That is actual important word. And compare and contrast, maybe you can make a table. You can have parameters. You can write what is about. But that requires quite a bit of knowledge to make it. If you're a little not very clear on the full concept, then you can make separately. But again, you have to repeat many times. It may consume a lot of time as well. So if you have a key word like simple means equal chance, and block means it's predominantly doing for a group balance. Stratified commonly we do for cases, for example, if you do want to study on heart failures, you don't want to see what is effect in already patient with a known heart failure or maybe a new MI or hypertensive heart failure, some other reasons, you would divide them before itself. You want to see separately. So that's why putting everything together may confound your. So that's why the certification is commonly done. Adaptive trial designs, everyone knows during COVID, many trials they use the adaptive trial designs and all those things. If you know one example for each from the critical care trial, it'll be very great. If you keep right example, that is a very good to know concept. So each trial will actually have a different way of randomization. Nowadays, many trials are predominantly stratified or block based on the need. And the nice to know point is predominantly what is the role of a DMSB. So actually the trial monitoring safety board and how they operate and the new trial design, adaptive trial design is a quite a good questions nowadays because of recent COVID trials. You should be a little more thorough on those trials. And specifically on blinding, we should little bit of more clarity you need. Many people will confuse with the allocation concealment. Both are slightly different concept. What Dr. Wallace pointed out, allocation concealment happened before recruitment itself. Once recruitment happens, then only blinding comes. So these two important concepts you should be aware of it.
I'll move on, sir.
Yeah, if no other question, you can move on. Yeah, go a little faster.
Yes, sir. Yes, sir. Sorry. So the next topic is reverse barrier nursing. It comes as so the problem questions here is define reverse barrier nursing and compare it with positive pressure isolation. What are the ICU precautions for some particular diseases can be asked. What are the contact and droplet and airborne precautions that should be taken? And some positive and negative pressure isolation also may be asked. So coming to isolation person, there are two types of isolation. One is the source isolation, which is called the barrier nursing, and also the protective isolation, which is a reverse barrier nursing. The difference between these two is you should know the difference between these two. The primary goal of barrier nursing or source isolation is to contain the infection at the source. So this is to prevent the infection from spreading to the staff, visitors, or other patients. In reverse barrier, you're trying to protect the host from getting the infection. So these are mostly vulnerable patients, especially patients with severe neutropenia with the ANC less than 500. You're ideally putting in the patient into a protective isolation. In barrier nursing, a single room is preferred as in terms of contact isolation. If it's an airborne isolation, a negative pressure room is preferred, especially for conditions like TB, measles, and varicella with 12 air exchanges per hour. In reverse barrier, a single room is preferred with an ideally uh, positive pressure and HEPA filtered with a protected environment with 12 air exchanges. So the PPE, depending on the condition in barrier nursing, if it is a contact isolation, glove, mask, and your PPE is fine. Or if it is airborne, you might have to go for a N95 or other airborne precautions. In reverse barrier, you should have a strict hand hygiene, sterile equipments, and sterile glove, and you should have a surgical mask for all the visitors. Um, dedicated equipments are required for barrier nursing. Try to limit the patient movement and transfer, and whenever they are transferred, the patient should be masked in both cases. So the de-isolation criteria in terms of source isolation, it is pathogen specific. It is either symptom isolation, symptom resolution plus negative cultures, and depending on the condition, it can vary. In reverse barrier, de-isolation occurs when the patient has a recovery of immune function, that is, your neutropenia has resolved or a patient is clinically stable. There are certain risk and downside of isolation. One is delay in caring of donning and doffing can delay the treatment that is provided, especially in case of emergency. And there is a risk to a healthcare worker also if the PPE is breached. In terms of reverse barrier, isolating the patient may have some psychological stress and higher incidence of delirium in these patients. Limit the number of visitors that are going to come in, and waste disposal in barrier nursing or source isolation. All this can be treated as biohazardous, and depending on the case, other waste is disposed. So what are the precautions to be taken? So based on the type of infection, and appropriate IPC should be maintained. So the standard precautions must be applied to all patients at all time. The components of standard precautions include your hand hygiene. You have to know the 5 steps of hand hygiene, and the 5 moments of hand hygiene, and the 6 steps of hand hygiene. Personal protective equipment, depending on the case, you need to decide, or depending on the procedure that you're doing, you need to have some amount of PP involved over all cases. Handling and disposal of sharps, management and decontamination of linen, environmental cleaning, biomedical waste management, and respiratory hygiene and cough etiquettes. These should be divided, applied to all patients at all time. So there are certain transmission-based precautions, which includes your contact precautions. Any disease which is has an increased risk of contact transmission should follow contact precautions, especially your MDR organisms, your MRSA, vancomycin-resistant enterococci, Clostridioides difficile, Candida, etc. You must follow contact precautions. And droplet precautions, anything which has a risk for droplet transfer, especially your strep pharyngitis, diphtheria, mumps, influenza, COVID-19 also needs to take droplet precautions. Airborne precautions are used mainly for diseases like TB, measles, chickenpox, disseminated herpes zoster, and COVID-19 also. COVID-19, I said in both because in a regular routine care of COVID-19, you can actually take droplet precautions with mask and general PPE. For when you are performing an aerosol generating procedure, you can go for airborne precautions and negative pressure isolation rooms. So isolation facilities, depending on the pressurization, it can be divided into neutral pressure, positive pressure, and negative pressure. So positive pressurization, where the pressure inside the room is positive with respect to the surrounding. So whenever you open the room, the air moves out of the room, that is exfiltrates the room. And you need to have at least 12 air exchanges per hour, and at least 2 complete air exchanges per hour. Negative pressurization, the pressure inside the room is negative compared to the surroundings. So the air infiltrates the room. This is mainly for infective cases like MDR organisms, where you need to have a negative pressure isolation room. Coming back to the question, if they ask you about infection control in a particular organism like Candida auris, so you know that it is an emerging fungus that is posing a serious health threat, and it is multi-drug resistant. It can colonize it is very difficult to identify. It can survive on surfaces for very long time, and it has a propensity to cause outbreaks. So in such cases, standard precautions for all, plus this for Canada auris is specific, you need to have a contact precautions and barrier nursing. Uh, com Coming to specifically hand hygiene, if for Canada auris, alcohol-based sanitizer is preferred in Canada auris, and environmental cleaning, most of the common hospital disinfectants may not be effective. So hydrogen peroxide, peracetic acid with a contact period of 4 minutes, or your isopropyl alcohol with a quaternary ammonium compound for 1 minute is basically used. In Clostridium difficile, again, it is standard plus contact precautions. You can explain on standard and contact precautions. And ideally, these patients should be isolated in a single room with toilet facilities. You need to have you need to maintain standard precautions for all patients. So PPE, hand hygiene. With respect to hand hygiene, alcohol-based hand rubs are ineffective against spores of Clostridium. So you need to go for a soap and water hand hygiene. So environment cleaning, when you need to target sporicidal agents. So at least 1,000 ppm of sodium hypochlorite may be used, and clinical waste disposal is also important. And in antimicrobial stewardship is also important when it comes to infection control and Clostridium difficile. De-isolation criteria when in Clostridium difficile is at least 48 hours after the diarrhea has ceased and the patient has started passing formed stools. To summarize, you need to know that reverse barrier is for protecting the immunocompromised from external pathogens, and different isolation techniques, uh, and what are the contact and other different precautions that you take. Environmental cleaning. It's good to know what is the difference between positive and negative pressure isolation rooms, and CDC guidelines for Canada auris. And nice to know the role of transplant and neutropenic care. Of role in transplant and neutropenic care. Thank you.
Thanks, Dr. Rahul. But this is one of the most important topic, because almost 5-10 years before, every second paper will have question on Clostridium difficile. But nowadays, the Canada RS has become a bigger problem, and definitely Canada RS questions actually are expected. And predominantly, you know that it spreads just from one patient to other patients. Predominantly, we need more like a contact isolation than anything else. So that is the terminology you should use when you write, and what kind of precautions, and what is the role of reverse barrier in terms of the purpose, and how you define why it is done, and what are the common situations. Maybe if you group it like this, it will be very useful for you also write it up. And in a similar context, sometimes we may get questions on outbreaks, like MRSA outbreaks, VRE outbreaks. How will you define outbreaks predominantly, and how will you step by step manage outbreaks? That also is quite common questions. All revolve around the same concept of isolation, identification, and quick control measures, and repeated follow-up. This should be the key message you should have. Yeah, you can move to next one.
Oh, sorry. So the next topic is sample size calculation. This is slightly more difficult or boring topic compared to the rest of the things. So the question that can be asked is, they can give you uh, a parameter and tell you to define the effect size. What is effect size, and how does effect size influence sample size calculation and study power? And discuss the rationale of planning interim analysis. A word on interim analysis also will be discussed. So in any study, it is not possible to study the whole population because of multiple reasons. So you need to select a sample population from the reference population. So they need to represent this particular population of study. So if the sample size that you're selecting is too small, you are not able to detect a precise difference, and you cannot generalize it to the rest of the population. If the sample size is too large, any risk of intervention, I mean, you're putting more patients at risk of intervention and making it more unethical to continue the study. And there is also wastage of precious resources. So it is always ideal to find out the optimum sample size. So the advantage of sample size is, one is choosing an ideal sample size. It is more practical, cost effective. It is more feasible, efficient, and ethically also better to have a ideal sample size. So there are certain steps for sample size calculation. The first one is to formulate a research question, and you need to define the population under study. So once you define the population under study, you need to state a null and alternate hypothesis. Null hypothesis is where there is no difference among the groups or no association between the predictor and outcome variable. This hypothesis needs to be tested. Alternate hypothesis is what we are trying to prove, and this cannot be tested directly. So it is accepted by exclusion if the test of significance rejects the null hypothesis. The third step is choosing a primary outcome and suitable statistical test. And then you have to select the significance level and the power of the study. Then calculating sample size can be done manually with different formulas we will discuss, and also with use of certain computer softwares. So Sarah, there are certain key statistical concepts that you have to know before you go for sample size determination. One is you have to know what is type 1 error and type 2 error, what is the alpha and beta value, and you need to know the power of the study, which is nothing but 1 minus your beta error. You need to know what is your effect size, standard deviation, and the dropout rate. So effect size is the difference in the value of variable in the control group and the test group. If the effect size is high, meaning like if some variable is studied and the difference with that variable between the control and the test group is very large, you can use a small sample size to prove your effect. So if the difference between the effect, if difference between the control and the test group is very low, you need a larger sample size to prove that this is significant. So the effect size may be a numerical value in a continuous outcome variable. For example, hemoglobin for a drug, given hemoglobin reduced by increased by one drug is 1 deciliter and another drug is 5. So the effect size is the difference between these two, that is 4. So point of some So the importance of conducting a pilot study is that there are certain parameters like prevalence, variance, effect size, standard deviation, also the dropout rate, which has to be taken from a previous study. So when that is not available, pilot studies can be planned. So this is a small scale study conducted prior to the actual large scale study to assess the feasibility and scientific validity of this particular intervention. A word on interim analysis in clinical trials. An interim analysis is any assessment of data done during the patient enrollment time or during the follow-up stages, with an objective of assessing the performance, quality of the data collected, and also the treatment effects. It is basically to make sure that the maximum number of patients receive the most effective treatment at the earliest stages, and also ethical and economical details are also taken into consideration. So you know that all these clinical trials are expensive, so it may also if you don't have enough evidence, there's no point continuing the trial maybe. So there can be different reasons why you may have to stop the trial in between after the interim analysis. One is you already have an evidence of benefit. So if the treatment demonstrates unequivocal efficacy, that is large effect size, the difference between effects, the control and the test group is very large, the trial may be stopped, and the same that good intervention may be offered to all the participants. If there is an evidence of harm, if there is unacceptable adverse events or mortality may prompt early termination to avoid further participant risk. If the interim analysis suggests that the trial is unlikely to achieve any objectives, that is, then it can be um, because of utility, it can be stopped in between. And there are certain other reasons also. Because of recruitment failure, there can be gross protocol violations, and there can be poor data quality, and you have an external evidence rendering this trial unethical during the study. So these are all reasons why you may have to stop the trial in between. And for doing the interim analysis, you have several statistical methods. One is the alpha spending function. A concept is mainly to control the type 1 error. The O'Brien-Fleming method, which is the most commonly used method, and you have other Pocock method and the Peto method also. So when you're trying to formulate an answer, when the question is asked for sample size, you know that the sample size represents a reference population. You can mention the advantages of sample size calculation. You can, what are the steps of sample size calculation, and also the key parameters, what all parameters you have to know for calculating the sample size. A different sample size, calculation for different study designs. The formula for is different for different study designs and outcomes. For example, for a cross-sectional study and a clinical study, the formula is very different. So depending on the study that you're doing, you have to identify the formula and you need to. So if you can remember these formulas, then it is good. Summarize the effect size we have already mentioned. So there is a difference between the outcome between test and control. So in this particular question, where protocol A is, the difference between mortality, the 28-day mortality was 35 to 28%. 28%. The effect size is the difference between these two. So the larger the effect size, smaller the sample required. And you need to know about interim analysis for checking the safety, efficacy, and futility. It is good to know different consort guidelines. You need to read through the consort guidelines. And nice to know the role of adaptive designs and Bayesian interim analysis. So, and how to reduce biases. Thank you.
Thank you, Dr. Rahul, for your presentation. And any queries we can address here. And because this is a quite a tough topic, and everyone knows, it's very difficult to remember many things because a lot of numbers are involved. But try to remember the key the wordings that you mentioned, and because that is quite important. Here, the effect size is one of the most important thing when you consider the sample size, especially for interventional trials per se. And the many randomized trials, they stop in after interim analysis, either because of a clear-cut benefit or a clear-cut harm. That means no need to actually continue to recruit more patients, and already the results are quite evident. That is one of the reasons interim is done, and as well as to find regarding the safety, any more adverse event in one side, so that more patients may not be recruited. These two things are a quite important concept when you write an interim analysis to be mentioned. Okay. So while I just clarify the queries, Rahul, can you please unshare it, and
Yes, sir.
you can share it. Any questions from these 8 topics? Anyone had any queries or any other comments? If no more queries, then we can just move to the next topic. I invite Dr. Varun Eman. He's a critical care specialist and consultant in the Manipal Hospitals, Bangalore. And thank you, Varun. Please carry on.
Yes, sir. Thank you, sir. Good evening. Am I audible, sir?
Yes, Varun, you are audible. Carry on.
Yes, sir. So the next topic is nutrition. So we have a few questions regarding the nutrition. The first question is what is conditionally essential amino acids and immunonutrition, and outline the role of different immunonutrition in critically ill patients, critically evaluate the evidence supporting immunonutrition in trauma and burns patients. So what is conditionally essential amino acids? It is basically these amino acids are normally synthesized in the body, but during stress, due to increased demands, we might have to supplement those. So there is increased metabolic demand, altered metabolism, or organ dysfunction where we need to probably supplement these essential amino acids. Immunonutrition is basically modulating effect on immune and inflammation. So these are the disease modulating nutrients, attenuate metabolic responses, prevent oxidative stress, and modulate immune response and probiotics to alter the gut environments. So ESPEN guidelines recommends that probably in upper GI surgical patients, in patients with mild sepsis, we can selectively use this amino acids, and lipid emulsions in ESPEN guidelines recommend fish oil enriched lipid emulsions also in certain subset of patients. ESPEN and SSCM guidelines on immunomodulation, particularly in subset of patients of traumatic brain injury and surgical ICU patients. Formulations containing arginine can be used. Strong recommendations is there. In patients with ARDS, but the guidelines position inconsistent currently made for the use. So, all the evidence which improve levels and mortality and organ failures. So in a subset of patients of trauma and burns, so use of glutamine and arginine considered. So glutamine is the most abundant amino acids, which is mainly synthesized in the muscle. In catabolic state, there's more concerns in moderate to severe TBI, probably supplementation of glutamine is recommended in a dosage of 0.3 to 0.5 gram per kg per day. That is 1 to 2 weeks during enteral or parental nutrition. So, fatty acids and supplemented, but no conclusive evidence. Clinical evidence is present. So in Burns patient, there was a trial called Re-Energize trial, which was a multi-center randomized control trial in major burns. So they did not find any evidence to suggest there is a group differences in 6-month mortality in usage of enteral glutamine in these patients. So current recommendation of use of glutamine in burns is also a problem. These we can go through. Let's see here. So the other thing is redox trial, where there's this is a randomized trial usage of glutamine critically ill patients. So the early provision of glutamine or antioxidant did not improve any clinical outcomes, and actually there was increase in mortality among the critically ill patients with multi-organ failure. So we should be careful in using the glutamine in all critically ill patients. So current question is explain the concept of conditionally essential amino acids, outline role of different immunonutrition, and evaluating the evidence supporting immunonutrition. So must know is like amino acid like glutamine, arginine during stress and due to increased demand, and immunomodulatory amino acids and other omega-3 fatty acids. And the other good to know things are what is the evidence, whether there is any reduction in length of stay, infections, and due to mixed results in population of critically ill patients with sepsis, and guideline recommendation of aspirin and aspirin. The other controversial topics regarding glutamine usages of the redox trials, probably we need to know that. And probably future things are personalized nutrition based biomarker assessment, and then probably supplementing the essential or conditional essential amino acids.
Thanks for
That is, sir.
See, the nutrition is a very, very vast topic, and there's a very high scope of getting hard questions. Because actually nutrition, it starts from your pathophysiology to mechanisms to assessment and the way you give nutrition, complications, and etc. etc. It's quite a vast topic, and so many literatures are available. So in this very less touched topic is on immunonutrition, because very handful of meta-analysis only are available, and the evidence is quite wavering. It's not too strong. I mean, a lot of concept papers are there. So likely that there can be a question in this topic. And so many nutrition guidelines you have, and the recommendation are more or less same. So only thing is you should little organize the answers. That is the most important one. And you just mentioned regarding what are they and why it is important. And by supplementing, what you will be achieving it. What is the reason to supplement? What are the evidence telling why you should supplement? This is the more important base for the answer. And rest of the things you mentioned trials, what are the trial tells, pros and cons are slightly more the message we will be giving it. So redox is the most important trial on glutamine, even it's intravenous glutamine. That is the biggest trial available with us. So even if you mention the redox trial name and what it is about, it's decently good enough. And I hope that we will be already knowing all these things. And many times I have seen people, they don't write well in this topic. So predominantly organization is the one that is the key when you write any answer in the nutrition, because you know more in the nutrition, you write more, you will miss on the important points. That's the only message, because I have corrected many papers. I have seen that they write a lot of things, but they won't miss upon the important key aspects of the question that is asked. In this, if you read the last question on critically evaluate, that means you have to appraise what is the pros and cons in giving nutrition in drama and not giving in drama. What is your pros and cons points? That actually you have to describe more in detail. And the second question is outline the role. That means slightly you give a outline is decently good enough. So that you should be knowing it what exactly to write in each questions. Yeah. Yeah, Varun.
Yeah. So the next topic is nutrition assessment in ICU. The questions are describe validated tools used to assess nutrition status in critically ill patient and a comprehensive nutritional management plan for a 40% flame burns patient. So what are the problems we can see in assessment of nutrition in ICU patients is there are varied parameters, and in critically ill patients we find them having edema, fluids, use of diuretics. The confounding factors are infection, inflammation, injury. So these things usually will have a problem in assessment of nutrition. So the ASPEN guidelines suggest not using traditional nutrition indicators, so as they are not validated in critical care patients. So what is the problem is the acute and chronic malnutrition plus comorbid states and stress-induced inflammation cause increased catabolism and causes nutritional risk in critically ill patients, and that results in increased ICU length of stay, ventilator, and other parameters which we usually see. So what nutrition screening tools can be used for hospitalized patient particularly are multiple tools are there. MUST, NRS, MNA, and the SGA, which we use, Nutrix score, unmodified Nutrix score, which we use commonly in critically ill patients. So the scoring systems have been described well in all the available data which we see. So the NRS, which was developed by ASPEN guidelines, it contains a nutrition status, disease severity, and age adjustment. And the interpretation is score of less than 3, there is no nutritional support required, and rescreening is required weekly. More than 3, they are at risk for malnutrition. So hence initiation of nutrition support is very important. The other score is the MUST score, that is malnutrition universal screening tool. The important score is the Nutrix score, which was asked the last exam, which contains 6 variables. So age, Apache, SOFA score, comorbidities, days from hospital to ICU admission, and interleukin 6 level is an optional, which is excluded in the modified Nutrix score. So 0 to 4 interpretation, we have less likely to benefit from aggressive nutrition support. 5 to 9 is are the patients who are high risk and maybe benefit from early and optimal nutrition therapy. So the clinical utility is higher the nutrition score. The studies say that there is a higher 28 and 80-day mortality, and hence the nutritional adequacy and delivery of adequate protein energy is very important in these patients. Global validation is seen in the Nutrix score, and it is a better predictor for nutritional benefit. So the other thing which we commonly use is the subjective global assessment. It is best for baseline nutrition assessment. So components are history and physical examination, which is as a bedside tool. We can use this subjective global assessment. And classification we can do as well-nourished, mild to moderate malnourishment, and severe malnourishment. So based on these things, we need to plan for the nutrition plan for the patient. The other newer one is the GLIM criteria, which contains a phenotypic criteria and etiological criteria. And based on this, the risk stratification and assessment of the patient is done, and nutritional plan is made. Particularly in burns patient, there's increased need to supplement nutrition early because of all the pathophysiological changes we see. So the challenges would be they're already in hypermetabolic and hypercatabolic state, and early on ongoing changes in metabolism, muscle protein breakdown, micronutrient losses are there. And there is also a risk of overfeeding in these kind of patients. The normal nutritional assessment tools which we use normal protein requirements in burns patient is in normal adult patient 1.5 to 2 gram per kg per day. Sometimes in burn patient we need to supplement up to 2.5 to 3 gram per kg per day. The goal is to maintain normal nitrogen balance and support the wound healing in these patients. The role of immunonutrition, particularly in burns patients, the use of arginine, glutamine, and other antioxidants like vitamin C, vitamin E, and micronutrients are also studied. But current evidence have shown, these small studies have shown significant mortality benefits. But the recent redox and meta plus trials were not able to suggest any improvement in outcomes, and also even reported a trend to an harmful outcome in these subset of patients. So the trace elements which can be used in burns are vitamin A, C, E, copper, selenium, and zinc according to the recommended guidelines which we usually see. So if we have to plan a nutritional for a nutrition for a 40% flame burns, generally we need to consider energy requirement, protein requirement, and other supplemental immunonutrition or micronutrients. So we calculate the calorie requirement per kg per day and protein requirement, and then we need to plan accordingly. And we can divide into micronutrients and macronutrients. The other important thing which we have to consider is fluid and electrolyte balance in the initial resuscitation of burns patients. So commonly used is the Parkland formula of fluid resuscitation in the initial 24 to 48 hours. Then monitoring of important electrolytes, which can cause some harm or can cause some derangements because of poor resuscitation also. So currently, the questions were validated tools to assess nutritional status, and these include what we need to know is the Nutri-Score, SGA, and MUST. Nutri-Score, which was asked in the last year question paper. So these we need to know it in detail. And the other thing is the burn nutrition, commonly asked question burns patients. The other good to know concepts are electrolyte monitoring, wound healing, and literature, the guidelines, what ASPEN and ESPEN guidelines say. The role of trace elements and role of UHT in nutrition assessments are the few small topics which we need to, which are nice to know to add on to additional points.
Thanks, Dr. Varun. Okay, it's a pretty straightforward question because definitely one question will come from nutrition. There's no doubt at all. And because last time Nutri-Score was there, and it is good to know all the assessment tools, at least the broad base of all these tools. And burns is quite good topic and very less seen in many hospitals. That is a major challenge. A lot of decent literature is available and how to provide the basic first line care. Many times burns means we restrict ourselves to the fluid management and temperature management, infection, source control, etc., etc. But nutrition is quite important topic. A lot of literature is available and how to give, and a lot of upcoming literature with proactive nasovaginal feeds, because it's very difficult to achieve a quite high calories with a nasogastric. Literature is slowly expanding, so there is a chance that you may get on a nasovaginal tube feeding as well. And more the burns, more the calorie needs. It's very difficult to achieve. So we have to sometimes supplement with a little bit of high calorie the supplements instead of routine 1 kilocalorie per ml. Sometimes we go up to 2 kilocalorie per ml concentrated feed also. These are the quite important thing you should always know. Trace elements, glutamine decent evidence is there, especially oral rather than intravenous, and slowly coming up. And this is a very actively expanding literature is there.
So the next important topic is nutrition route and time. So we can consider a question where a 40-year-old female with morbid obesity, severe acute pancreatitis is admitted to the ICU and has been NPO for 5 days. Developed ARDS, required proning, and has significant third spacing with a low albumin and creatinine of 2.6. So the nutritional challenges specific to acute pancreatitis and the nasogastric versus nasogastric feeding in these patients, and early and late parenteral nutrition in these patients, so which are divided into 3 and 4 marks. So generally what was done in the past is prolonged fasting NDM for these patients to reduce pain and inflammation. The current concepts are changing. So the pathophysiology of malnutrition is the resting energy expenditure is known in pancreatitis patients. So the basic cause being severe inflammation, and these patients have a higher metabolic rate and also insulin resistance. They might also have hypertriglyceridemia, which is also a cause for pancreatitis. So we need to be considering that factor also. So the general concepts in acute pancreatitis is they should be considered moderate to high nutritional risk, and these patients should be screened using validated screening tools, which we have already discussed. And early oral feeding should be offered as soon as clinically tolerated in mild and moderate pancreatitis patients. Generally, the recommendation is low fat and soft oral diet, and always enteral nutrition is preferred over parenteral nutrition. So if the enteral nutrition is patient is not able to take orally, the nasogastric tube feeding is the most preferred one. And if that is not tolerated, if there is gastric intolerance, probably nasal jejunal tube can also be used. The parenteral nutrition should be administered in patients only in severe acute pancreatitis where they do not tolerate enteral nutrition or we are not able to achieve the targeted nutrition requirements. So in a patient with severe acute pancreatitis, if the intraabdominal pressure is less than 15, then enteral nutrition can be started easily. Only in patient with intraabdominal pressure of more than 15 or there is abdominal compartment syndrome, then probably we need to consider the parenteral nutrition earlier. So in presence of ACS, definitely the enteral nutrition should be stopped temporarily and reassessment should be done at frequent intervals. So in malnourished patients, probably this is chronic pancreatitis. We need to supplement small feedings of 5 to 6 small meals per day. When enteral nutrition is not feasible, parenteral nutrition should be considered with other immunonutrients which are generally recommended in severe acute pancreatitis. So normal nutritional goals which we achieve has to be followed in these patients also. And other trace elements like glutamine has some role, and omega-3 fatty acids are also tried in acute pancreatitis. So the debate of nasogastric versus nasojejunal feeding. The current observation is that nasogastric route is as safe as nasojejunal route. So currently, when there is a patient with nasogastric feeding and he develops some gastric distension or gastric intolerance or increase in the pain and trickle, probably aspiration risk is there. Then probably post-viral replacement of NJ can be done, which is almost equal to nasogastric feeding. So the evidence which we see is the trials, the calories trial, where they critically ill ICU patients parenteral nutrition is the intervention which they compared enteral versus parenteral nutrition. So there was the primary outcome was 30-day all-cause mortality and secondary outcome was infection rate and other parameters which you see. So this study did not show any difference in 30-day mortality between enteral and parenteral nutrition. But enteral nutrition was associated with fewer infection rates and probably glycemic control also. the EPANIC trial, where the timing of parenteral nutrition in critically ill patients was studied. So early parenteral nutrition was started within 48 hours of ICU admission, and the other one is the late parenteral nutrition. So what they found out was late parenteral nutrition led to fewer infection rate, faster recovery, and reduced ICU stay without increasing in mortality. So hence this study suggests that we can delay parenteral nutrition. So there is no significant benefit in starting early parenteral nutrition in critically ill patients. So this is the meta-analysis which was done in NJ versus NG feeds, and they concluded that mesogastric feeding is safe and well tolerated when compared to NJ feeds. So coming back to the question, for a severe acute pancreatitis, the nutrition challenges which we discussed were enteral nutrition, NJ versus NG feeds, and early parenteral nutrition in certain subset of patients. So what we need to understand is the gastrointestinal intolerance in acute pancreatitis patients and severe acute pancreatitis patients particularly. And if required, an NJ feed bypassing the pylorus can help in decreasing gastrointestinal dysfunction. So the other things which we need to know is the ASPEN and ESPEN criteria, where they're particularly given early enteral nutrition is preferred, and other trials which we just discussed is calories and EPANIC trials. The role of pharmaconutrition and indirect calorimetry in assessment of nutritional planning. So indirect calorimetry is an important topic which generally is considered gold standard, but it is difficult to do in bedside of the patient. So it is nice to know how it is done and what are the steps which we see in indirect calorimetry, and what are the alternatives like Benedict formula which we use to calculate the calorie requirement in patients, generally in normal critically ill patients.
Thanks, Varun. Actually, it's a very common question of pancreatitis. The idea is actually sometimes you may get a case scenario like this, and you may actually have to describe the questions what is being given according to the context of the scenario provided. That is most important. You cannot write too general. The case scenario is provided specifically to address the specific challenges in the case scenario. So that is more important. You'll be knowing many things regarding pancreatitis. How will you extrapolate the knowledge, what you know, to the context of the scenario provided is the most important one. Because you can see the questions are evaluated challenges specific to acute pancreatitis. You can't write in general. What are the more specific thing you have to mention it. Similarly, compare and contrast early and parenteral nutrition in this patient. Exactly how things are. Okay. And that way. So we will move to another two questions. We have a little short of time, and Dr. Arun, I requested a little go
Yes, sir.
only on the key points. Yeah, thank
Sure.
you.
So the gut microbiome, what is the role of microbiome current emerging concept of gut microbiome and dysbiosis and probiotics and STD in preserved gut health. So normally gut microbiome maintains mucosal integrity and modulates immunity. There is gut brain axis, gut lung axis, and organ crosstalk, which we see where gut can influence the other organs in critically ill patients particularly. So they can influence the progression of disease and trajectory of recovery in our subset of patients. So this needs to be understood in detail. Normally, whatever intervention we do in ICUs, like antibiotic